Julia Baptista, who's a principal clinical scientist from the Exeter laboratory. And I've certainly worked closely with her with the R14 work that she's doing, which has been immensely productive in finding diagnoses for acutely unwell children with likely monogenic disorders. So over to you, Julia, and thank you.
Thank you. Good morning. It is a pleasure to be here and tell you a little bit more about the R14 service, which is the Exome service for acutely unwell children. I will start by doing things a bit upside down and start with a case discussion. So this family had a baby who died. And the baby presented with respiratory illness when he was 6 months of age. He also had some fibroelastosis with giant mitochondria in the myocytes and fat deposition in the liver. I'll give you 2 seconds to think about the case and perhaps even put in the chat if you think genetic testing would be appropriate for this child, and maybe perhaps guess the diagnosis or put 2 or 3 diagnoses that you think, genetic diagnoses that you would think for this child. I can't see the chat, but hopefully there are a few things in there. And what we did in this, for this family was a trio exome analysis where we looked at the samples for the child, the mother and the father, and we looked at all 23,000 genes. We call a gene agnostic approach. And what we identified in this family, so the child had a maternally inherited frameshift variant in the TAS gene. So it was a diagnosis of Barth syndrome. And of course, it was very important in this family because there is a recurrence risk since the variant is maternally inherited. Another example, in this case, we have a family where there is consanguinity, and there was just a first child with congenital heart disease. They also had a range of other anomalies involving other systems, so some jaundice, coarse facial features, excess hair, and they also had some abnormalities of their toenails and their thumbs and their toes. Again, we did a rapid exome sequencing in this case, and we identified a diagnosis. So again, if you want to put on a chat or think about what kind of genes you think would be the diagnosis in this case, please feel free to do that. And what we identified in this case was a homozygous variant in the PIG-N gene, which is a gene that causes hypotonia, seizures, and multiple congenital anomalies, including cardiac defects. It's a recessive condition, and in this case, both parents were carriers of this variant that was clearly pathogenic. And of course, again, there's a recurrence risk of 25% for a future pregnancy. So these 2 cases are examples of referrals that we receive in our service. And it is a service, as I said, for acutely unwell children, but it could also be for cases where the child is deceased and the family is looking for a diagnosis to manage a current pregnancy. So we started doing exome sequencing in Exeter back in 2013, and we use the service to analyze families that require urgent diagnosis, but there's also a lot of non-urgent work that is done in parallel. We started the urgent R14 service in the 1st of October of 2019. And as I said, this service is for those patients that need a rapid diagnosis, but we run the service alongside the R89 service, which is non-urgent, but it's also children that are likely to have a monogenic disorder. So just to spend a little bit of time thinking about what is whole exome sequencing and what are we doing when we do this diagnostic test. It is a test that is looking at all 23,000 known human genes. Of course, that involves genes that are already known to cause disease, but also novel genes and genes of unknown significance. And that is important because we might end up with a lot of uncertainty for these families. Although we are looking at all the genes, we are not looking at all of each single gene. So we are focusing only on the exons, and that is the protein coding regions of each gene. So in total, we are actually only looking at around 1.6% of the human genome. But we do know that most disease-causing variants will be located in those regions. And of course, as I showed with the first two cases that we discussed, the results can help guide management, treatment decisions, and predict prognosis for these patients. In the first year of the R14 service, we analyzed nearly 520 families. Most of the children will be in neonatal intensive care, pediatric intensive care, current pregnancies, or other indications where we are thinking that we might be looking at a treatable disorder, and a quick treatment would be really helpful. And this is just to show the spread of referrals all across the nation. So it's a national service. And in terms of how we analyze these families, we tend to do a trio, which I showed in the example, where you analyze the mother, the father, and the child. And 90% of the strategies that we do is using a trio, but sometimes it's not possible. One of the parents might not be available, and it is possible to do other types of analysis when you don't have a trio. Our analysis by using a trio is a gene agnostic approach, as I explained, looking at variants that fit the different modes of inheritance. And I'll just go very quickly. So we are looking for variants that are compound heterozygous in the child, homozygous in the child, de novo that would be compatible with autosomal dominant disorders. We also are able to look at X-linked variants. And as I said, when a trio is not available, we might be able to look at the DNA of the child alone or the child with one of the parents. In this case, we will still sequence a whole exome, so the 23,000 genes. However, we are not able to analyze all of the genes. So what we do in this case is we analyze a subset of genes using virtual panels. In terms of diagnostic yield, we identify diagnosis for around 37% of the patients. And this is just a list of some of the diagnoses we have identified with referrals with cardiomyopathy. So if I just go a little bit more in detail. So we have different groups of disorders. So we have the myopathies, we have the rhizopathies, which are actually the top category of diagnosis that we identify. And it is really important and impactful to identify this diagnosis because there is treatment. You can have MEK inhibition treatment for patients with rhizopathies. And these cases can also be picked up prenatally. So through the R21 service, which is prenatal exomes for a baby that has an abnormal ultrasound. The treatment requires a genetic diagnosis, so it is crucial to refer those children for genetic diagnosis. And we also have the group of mitochondrial disorders within this diagnosis. And broader congenital anomalies like Alagille syndrome, for example. In terms of congenital heart defects diagnosis, again, we see the rhizopathies. We see cases like the PIG-N that I talked about. So children with more complex presentations and involving multiple system anomalies. In terms of diagnostic yield for our cardiac referrals, we are pretty much in line with the rest of the other referrals, finding a diagnosis in 35-36% of these referrals. We also have a subgroup of patients that are referred, families that are referred because of sudden death in the family. Again, the diagnostic yield is pretty much in line with the other referrals, 35% diagnostic yield for this category of patients. And you can see some of the genetic diagnoses that we identify in these families. So the key messages are that, of course, whole exome sequencing is a powerful diagnostic tool to solve pediatric cardiac disorders. We are sequencing 23,000 genes by whole exome sequencing, and we are able to analyze all of those genes using a genetic approach only if we have samples from both parents and if both parents are unaffected. If these conditions are not met, we are not able to look at all 23,000 genes, and we then have to have a hypothesis that is driven by the phenotype on making this decision on which virtual panels should we apply. And it is somehow a limited analysis, but it can be very successful if the clinical picture is a strong clinical picture of a monogenic disorder. There is, of course, the potential for uncertainty, and many families end up with variants of uncertain significance that we need time to wait for knowledge to become available for us to be enabled to solve that uncertainty. And what we find from our experience is that multidisciplinary team working is absolutely essential to resolve these families, and working together with cardiologists, geneticists, scientists, protein modelers, and involving the research community has been invaluable in our experience to identify diagnosis for these families. Thank you very much.
Thank you very much, Julia. That was an incredibly eloquent talk, taking us through exome sequencing, etc. So we have a couple of questions, really, I guess one asking about the importance of genetic testing, particularly in this situation. And I think you very, very eloquently have taken us through the real power and benefit of considering TRIO and further genetic testing in the pediatric population. So thank you. We have a question from, let me just have a quick flick through. We have a question from Gethin Ellis about thanking you for your very interesting presentation, but also thinking about what is the age cutoff for testing, and are there any plans to extend this kind of testing to the older population?
That is an excellent question. Although we say this is pediatric testing, we have tested older patients. I can remember the older patient that we have tested was actually 40 years of age, and it was a patient who was experiencing regression. So there was the suspicion that you could have a treatable disorder in this case. So we don't have a cutoff set up in the criteria. We would be open to testing older patients if it was appropriate. And again, this would involve a discussion on a case-by-case basis. But certainly the bulk of our patients tend to be quite small, quite young. I would say the bulk of the children that we test are under 5.
Fantastic. In the interest of time, we'll hold the other questions until the end of the session. But Catherine, if I can move on now to introduce